Welcome to another video from 30 Minute Board Prep, and this is Gastroenterology and Hepatology series, and in this video we'll be talking about GERD and PUD. Once again, this is your ABI internal medicine board review video prep. So we'll talk about GERD and peptic ulcer disease in this video. So GERD is pretty common, clinically. You probably have seen multiple times. Every time you go to clinic, you probably have seen a patient with a GERD. What is GERD? It's a gastroesophageal reflux disease. It's due to your relaxed lower esophageal sphincter, you have a reflux of the gastric contents in the esophagus, which actually causing all the symptoms. The symptoms can be varied from cough, especially worse at nighttime, nocturnal cough, wheezing, chest pain, or hoarseness. This is also considered to be the most common cause of non-cardiac chest pain. And if you don't treat the GERD, you can progress to the Barrett's esophagus and also can lead to adenocarcinoma. And if the patient do not have any alarm symptoms, we will come to the treatment very shortly and what alarm symptoms are too. You can start them on empirically on a PPI. And the golden question is when to perform an EGD. So if patient do not have any alarm symptoms and you start with the treatment behavioral modification. That is the very first treatment of choice in any case patient with the GERD. The behavioral modification, which including weight loss. Your patient is smoking, you tell them to stop smoking. If they are going to bed right after eating food, tell them to avoid late evening meals, avoid like fried food, chocolate, mint, carbonated beverages, citrus. Those are the behavioral modification you have to review with the patient and make sure that patient is doing that. Initially you want to start them on empirically on a PPI, and if the patient is not responding, you give them about 6 to 8 weeks if patient is, and make sure that you are evaluating they are doing the lifestyle changes and also they are taking the medication. If they are compliant with the medication and also performing the lifestyle modification and not getting any better, the next step is increase the PPI to twice daily. And when I talked about alarm symptoms, if those are your melanoma, patient is reporting they have the stool, blood in the stool, anemia, weight loss, or dysphagia or dynaphagia, in those cases you need to do an EGD because those are alarm features and those indicate that there could be something else going on top of the the GERD, or GERD is probably not the only thing that you have to worry about there. Now, let's talk about PPI. This is a very important slide, high-yield slide, because everybody uses PPI nowadays. It's pretty common. So as a result, the side effect you have to know for the ABIM. They allow to test this. So it's the first line for therapy for the GERD. Know that it's associated with C. diff. There's a high risk of increased risk of Clostridium difficile infection, increased risk of pneumonia, and osteoporosis and hip fracture, and also some electrolyte problems such as hypomagnesemia. It's also seen here. If the patient is not, like I said, is not responding to the PPI, you need to increase it to 2 times daily. And if that's not responding, then you have to think about anti-reflux surgery as a treatment for the GERD. And one thing to remember is that there used to be a myth that the PPI decreases the Plavix or the clopidogrel efficacy, but now there's research has shown that there is no need to be changed. The Plavix not to be changed if the patient is already on Plavix, or a patient is has osteoporosis. You still can continue the PPI. You don't have to discontinue the PPI. All right, so we can go through one question here. We have a 42-year-old female presenting with nocturnal cough and heartburn. So we look at the question here. You need to ask yourself if it's a middle-aged person, and with there's no description of any alarm symptoms here. So typical GERD symptoms: nocturnal cough and heartburn. So what would be the next step? The next step would be start them on PPI daily. So whatever, before 30 minutes before the meals, tell them to take the PPI. On top of that, make sure that you talk about the lifestyle modification that we discussed a few minutes ago. Now, patient come back, maybe about 8 weeks later, patient comes back and tells you that, the symptoms are a little better, but not completely resolved. My nocturnal cough is gone, but heartburn is still there. So what would be the next step? The next step would be you tell them to increase the PPI to twice daily. So that would be the next step. Now, let's say this patient come in about 6 months later, their routine checkup come back and they'll tell you that, what, doc, my symptoms feels much better. I've been doing the lifestyle modification, also taking the PPI twice daily. So this is an important step. So then you have to cut back the PPI because your job is to make sure that patient take the PPI at the lowest dose and lowest frequency. So you can cut back, continue the PPI at lowest dose. You can cut by either start by decreasing the frequency, or you can tell them to stop decreasing the amount of PPI they're taking. So at the end of the day, you want to make sure that patient is taking the lowest PPI dosage. That will be a goal, and whatever that can control the symptoms. Now, let's say as opposed to this, in 3 months, patient come back and tells you that the symptoms are not getting any better, and or they tell you that what, I feel that I noted that I'm having blood in my poop, or having painful swallowing. Then your next step would be you refer the patient for an EGD, because that tells you that patient needs an EGD pretty emergently. Let's say the EGD performed and the EGD is showing a severe GERD. So this is a patient where you all know that patient is already on a 2 times BID dosing of PPI, which is highest dosing. On top of that, a patient also following the lifestyle modification and still and they're having symptoms. So EGD is still showing that patient still have GERD, severe GERD, and the next step would be manometry. The reason why you need to do manometry is because you need to do this is the case where you have to refer the patient for surgery. So before doing surgery, the fundoplication, you need to make sure that patient doesn't have an achalasia, because patient has good motility, esophageal motility. So that has to be done. A esophagus motility test has to be done prior to the surgical fundoplication. Otherwise, patient can have a iatrogenic achalasia. Now, we also need to make sure, if let's say the patient is EGD shows no esophagitis, then you need to, before surgery, you have to make sure to confirm the GERD, you need to refer the patient for 24-hour ambulatory pH monitoring. You can do either by a catheter or do a wireless capsule. There are multiple ways you can perform the ambulatory pH monitoring. The bottom line is that you need to make sure that patient in 24-hour period or 48-hour period, depending upon how long you're testing, patient should have the acidity. You should have the symptom correlate with the acidity. So that is something you want to make sure, because otherwise you have to assume you have to there is no acidity with the symptom onset. Then that's probably non-functional dyspepsia. Then you need to start them on TCA, some type of tricyclic antidepressant. Again, the last step would be the surgical fundoplication. Then before that, you need to do the manometry and also do the 24-hour ambulatory pH monitoring to confirm the GERD before doing the surgery. Now we're going to talk about Barrett's esophagus. This is a moderately important slide. The reason why I'm saying it's moderately important is because a lot of times you would see the patients in your clinic, or even for the board exam, they like to test you when to follow the patients with the Barrett's. So the bottom line is obviously if the patient has no dysplasia, the surveillance frequency is shorter, or if the patient has dysplasia, depending upon the dysplasia, the higher the dysplasia, the follow-up will be very shorter. So that is the bottom line, but you need to know how frequently you have to monitor this for patients. So with the chronic GERD symptoms, you have normally at your gastric esophageal junction, you have a squamous epithelium. So this squamous epithelium is replaced by a columnar epithelium in Barrett's esophagus. So that is what histologically happening. Now, the surveillance wise, if the patient has no dysplasia, so you do the GD and you send the tissue for the biopsy. Now the biopsy is showing no dysplasia. In that case, you can follow. You have still to do an EGD. You need to do an EGD in 3 to 5 years to make sure that there's no changes. Now, if the biopsy is showing a low grade dysplasia, then you need to do the EGD in 6 to 12 months. Now, you need, if PGD is showing high grade dysplasia, you need to do an endoscopic ablation. Now, this is a very, it's a curveball basically. If you have a nodule with dysplasia and the bed is around the nodule, then you do an endoscopic mucosal resection and a radiofrequency ablation. Now, this slide is important. You actually got it from the ACG website. So that's another good source to learn about the guidelines. I highly recommend going to the acg.com, and ACG website has a guidelines for different types of diseases. So you can actually, a lot of them are very short and you can just read them, and they're very concise, so that will help you to help with the guidelines regarding different types of chronic medical problems. Now, what about gastric polyps? Polyps can be associated with the multiple syndromes, like your familial adenomatous polyposis syndrome, FAP, or MIH associated polyposis syndrome. If the patient is, remember, the patient is 40 years younger or 40, younger than 40, and history with the EGD showing multiple polyps in the stomach, you need to do a colonoscopy to rule out FAP or the MIH. It's an important thing to remember. Now, the osseous disease or hereditary hemorrhagic telangiectasias are your angiodysplasias on the EGD, and telangiectasias on the finger, nasal, oral mucosa. They have a history. They will have a presence usually with the multiple nosebleeds. Here, Fujioka syndrome is basically patients who present with the perioral pigmentation and hamartomas in the GI tract that can bleed. They have an increased risk of GI cancer, and a GIST or your gastrointestinal stromal tumor is usually diagnosed in the US, and these tumor cells usually arise from the interstitial cells of Kajal. So that is an important point you need to also remember for the board exam purpose. They allow to test this histology trivia. Let's do a practice question here now. So we have a 43-year-old female male presents with a severe chest pain. Pain is retrosternal and worse with the breathing. So it's a pleuritic chest pain. On exam, subcutaneous emphysema, and chest X-ray shows left sided pleural effusion. So this pretty much tells you that patient has a pleuritic chest pain and on emphysema, subcutaneous emphysema on exam, and the chest X-ray showing some pleural effusion. And this is next step would be you need to suspect that there is esophageal rupture. So you need to do a gastrograph and swallow study, and that will obviously if most likely will show esophageal rupture. Again, the point here is to make sure that you don't do, if you're suspecting a esophageal rupture, please don't do a barium swallow, because barium can extravasate into your mediastinum. We don't want, obviously that can cause more damage, so we don't want that. You just do gastrographin. That will be the safest study to do in this scenario. Now, what about gastritis too? So we have two different types of broadly classified the gastritis into two. This erosive gastritis is where you see your typical patient in the ICU with not on PPI, or your patients on a ventilator, or burn patients. These patients can actually have something called, they have erosive gastritis, and this is why the patient need to be on the PPI. Patients on high dose, extremely high dose steroids. Patients on these patients need to be otherwise will be having erosive gastritis. Chronic gastritis is usually can caused by H. pylori or gastronoma. So we will talk about gastronoma in a bit. Basically, increased gastric production leads to hyperplastic polyps that causes this pernicious anemia, and high acidity leads to the chronic gastritis. So we will talk about chronic gastritis in a bit. Now, this is a very important slide. Make sure you go through this multiple times. They allow to test this part, and this is very important for your clinical practice too. Dyspepsia. So what is dyspepsia? So dyspepsia is basically, you can characterize it by three things, either with the postprandial fullness, early satiety, and epigastric discomfort. So the patient usually say that, oh, I have this vague pain in my epigastric area. So that's how the patient should present with, and they don't know how to describe it. They're probably going to say, oh, yeah, I have this vague discomfort in my epigastric area. Usually this is associated with the early satiety and also postprandial fullness. Now, how do you approach dyspepsia? This is a very important slide. Like I said, the way you need to make sure this is that approach is, make sure you classify patient, or you risk stratify the patient. So if the patient is elderly. If the patient is greater than 60 or 50, 60, they need to get an AGD. So you don't have to think about anything else. If the patient is more than 60 years old, they need to get an EGD with dyspepsia. Once they are less than 60, if they are once less than 60, if they have typical GERD symptoms, then you can actually treat them for GERD. Now, if they have alarm symptoms, we'll talk about alarm symptoms once again, then an EGD. If the patient has no GERD symptoms, meaning they have no nocturnal cough, no heartburn, then you need to you can check for H. pylori. Depending upon the H. pylori results, if H. pylori is positive, obviously you treat for H. pylori. If it's negative, then you can give a trial for PPI. So again, this is the algorithm. Once again, I'm going to go over it because it's very high yield. If the patient is less than 60, then you need to follow this algorithm. If they're elderly patient, then you need to do an EGD. Again, when I say less than 60, more than 60, again, this is also an arbitrary number. People come up with. The thing you need to remember is that clinically, if the patient has high risk factors, obviously, if the patient is 59 and a half or 59 and 11 months, you and other risk factors, then you just don't go over this. You probably, if the patient has risk factors, then you just go straight to the EGD. So that's why the clinical judgment is very important. You don't follow this guideline. This is just a suggestion, and if the patient fits the criteria, the patient has multiple risk factors, then you go straight to the EGD. But this is, again, this is just a suggestion. If they are less than 60 years of age and they have alarm features, what are the alarm features? Weight loss, very important. Unintentional weight loss is a very important alarm feature. If they are complaining of odynophagia, painful swallowing, dysphagia, unexplained iron deficiency anemia on the labs, persistent vomiting, family history of cancer, GI cancer, GI bleeding, or they have lymphadenopathy. If any of those things are present, and if they are less than 6 years of age, they still need to get an EGD. That is the bottom line here. Okay. Now, if they have typical GERD symptoms and less than 60 and no alarm symptoms, then you can treat them for GERD. Now, if they don't have any GERD symptoms, just check for H. pylori, and that is positive, treat them for H. pylori. If negative, then they can get a PPI therapy for 6 to 8 weeks. Again, this is a very important chart you need to for the board exams. Now, let's talk about a PUD, or peptic ulcer disease. Most common causes are NSAIDs and H. pylori, by hand. Those are the most common causes. Now, the PUD is basically your gastric and duodenal ulcers. H. pylori and NSAIDs, like I said, are the most common cause. However, there's something called Solinger-Ellison syndrome, which is actually the increased gastrin production, and Crohn's disease. Those are the other two things that can increase the risk of PUD. Now, what is the gold standard? Gold standard for the PUD is to diagnose the PUD is the endoscopy. Now, under trivia, you need to know gastric ulcers need to be biopsied to rule out malignancy. So, duodenal ulcers not need to be all the duodenal ulcers doesn't need to be biopsied, but all the gastric ulcers need to be biopsied because they are high risk of malignancy. That is why you need to risk. Now, H. pylori, I'll talk about how the diagnosis and stuff like that in the next slides. But you need to make sure that the patient has a low-grade MALT or mucosa-associated lymphoma. Then you need to treat for H. pylori, which results in the tumor shrinkage. And if the MALT is not responding to the H. pylori treatment, then they need to local radiation therapy and H. pylori testing. So that's very important. So ask yourself, does the patient need EGD? So you don't need an EGD to diagnose anybody with H. pylori, but if the patient is getting an EGD, regardless, or the patient is getting EGD for other causes, then you can follow this algorithm, EGD-based testing. If the patient does not need an EGD, okay, there is no indication for EGD, then you can just follow this algorithm. So what are the things you can do when you're already doing EGD? You can do a biopsy. You can do a biopsy urease test. You can send for bacterial culture and antibiotic sensitivity. Like I said, this is a gold standard EGD. Now, what is the non-EGD based testing? This is you testing for urea blood test or the antibody testing and or fecal antigen testing. So again, these are the non-EGD based testing. Now, the antibody testing is a very useless testing when it comes to if you want to follow up treatment. It does tells you that you are exposed to the H. pylori testing. It doesn't tell you you are cured from the H. pylori. However, urea blood test and the fecal antigen test can be used for as a follow-up study. Now, the trivia you need to make sure, the things you need to make sure is that patient has to be off the PPI when you're testing for urea blood test and the fecal antigen testing. Now, the treatment regimen is also important. I have like a few mnemonics I usually use. So the most common is the APC, which is your amoxicillin, PPI, clarithromycin, which is the most common treatment regimen for H. pylori. Now, remember that some patients can be allergic to the amoxicillin. So then in that case, you can use MOC, which is basically metronidazole, omeprazole, or clarithromycin. So APC or MOC are your standard treatment choices you have. If the patient is not responding to any of this treatment, okay, now you put them on the H. pylori, you recheck it and make sure you recheck with the either urease test or the stool antigen test. Both of them, let's say they come back to be positive, then you need to put them on the salvage therapy. The salvage therapy, we have two of the salvage therapy are available. One is your quadruple therapy, which is your flagyl, PPI, bismuth, tetracycline, or you can use amoxicillin, PPI, or levofloxacin. These are the two options when it comes to the salvage therapy. One thing you need to remember is that clarithromycin has a very high resistance, about 17% or so resistance in the country. So a lot of patients may not be responding to the initial therapy. Even flagyl has a lot of resistance, about 35 to 37%. Resistance. So that is another thing to remember. So even if you start them on therapy, and if the patient want to complain with the adherent to the therapy, but they can still endorse the symptoms. So make sure that you reassess the patient. That is why this quadruple therapy and the salvage therapies become important. Now, what is the thing you need to think about tetracycline? So remember tetracycline, whenever I talk about tetracycline, remember that they are associated with the odynophagia. So that is something you need to remember. So throughout this video, we will refer back to previous videos. That way you can refresh your memory. So one thing I also want to talk about is Soldier-Olsen syndrome, which is basically a gastrin-producing tumor in the mid-duodenum pancreas, which associated with the the MEN2B. So how do you test? Well, how do you present? You can present with the chronic diarrhea or peptic ulcer disease as seen on the EGD. How do you check for this? You check the gastrin level when they are fasting. So check the gastrin level, and after discontinuing the PPI, and if the gastrin level is more than 1,000. This is diagnostic in appropriate setting. The reason why I said appropriate setting, a lot of things can increases the gastrin level. Those are your renal failure, patients on PPI or hyperthyroidism. Those things can increases your gastrin level falsely high. So make sure that when you're testing for gastrin level, that is actually taken account for. Now, how do you diagnose? Again, once you have a suspicion for gastrinoma, you need to check them with either EUS or your somatostatin receptor scintigraphy to localize the tumor, and you treat with the PPI or surgery. Those are the treatment option for PPI. So with that being said, we're going to move to our last session, practice questions. So let's talk about a 49-year-old female with no past medical history. So she presents with the epigastric stomach discomfort, and she's also endorsing nocturnal cough. So typical GERD symptoms, right? So worse with the spicy food and chocolate, denies any weight loss, family history of cancer, difficulty or painful swallowing. So this is a typical patient who is not any high risk for any alarm features, who's not that high, not that old, is middle aged. Coming with the GERD symptoms. So what would be your next step? Your next step would be start the patient, treat the patient for GERD or start them on PPI. Now, let's say the same patient, with just epigastric discomfort. So in this case, we don't, there's no, GERD symptoms. We just have epigastric discomfort. It could be anything. There's no nocturnal cough, and there is no worse. The patient say it doesn't change, doesn't matter. Spicy food or chocolate doesn't change their symptoms. We don't know this is not a GERD symptom. So this again, going through the algorithm or going through thinking back, make sure that we don't know this is just a GERD symptom. So then you need to check for H. pylori. So depending on the test result for H. pylori, you can either, if it's positive, treat for H. pylori. If it's negative, you actually treat them for the GERD symptoms. Now, let's say the same patient explaining or complaining of unexplained weight loss or microscopic anemia on the labs. In that case, even if the patient is young, you need to go with the EGD due to the alarm feature. So I hope that approach was clear for dyspepsia. This is because it's a very heavily tested topic. So make sure you understand that, front to back. Let's do the next question. We have a 34-year-old female being evaluated for GERD symptoms. Now, she was started on once daily PPI about 10 weeks ago with some improvement. So she has some improvement, meaning she might say, oh yeah, my nocturnal cough is better, but I still have this stomach, the heartburn that's happening. So what would the next step? The next step is very important, evaluating for her adherence to the lifestyle changes. Okay, make sure that she's taking the medication 30 minutes before the meals. Make sure she's avoiding the triggers. Make sure she's taking the medication. So those are the things you need to make sure a patient is doing. And patients say that, oh, I am doing all those things. I'm adherent to the medication and also to the lifestyle changes. Next step would be patient is on once daily PPI. Make sure you switch to 2 times daily PPI. Let's say the patient 8 weeks later come back and she reports minimal improvement. In that case, you need to go with the 24-hour ambulatory pitch monitoring, and you can go with that will be the next step to do to confirm the PPI, the GERD. Question number 7, we have a 64-year-old male being evaluated for epigastric discomfort and nocturnal cough. So again, we have an elderly male here, and he is actually complaining of the typical GERD symptoms. But again, like I said, anybody who's elderly, you need to go directly to the EGD. So elderly patient can go directly to the EGD. That's the most important take-home point here. Now, let's say EGD showing buried esophagus and low-grade dysplasia. So obviously, like I said, the patient need a more frequent monitoring. In the case patient having low-grade dysplasia, they need an EGD in repeat EGD in 6 to 12 months. Now, let's say the repeat EGD shows high-grade dysplasia. In that case, you have to refer the patient to the endoscopic ablation. So that's a take-home point there. Next question, we have a 42-year-old male being evaluated for after treated for H. pylori with a triple therapy. Patient finished taking medications about 2 weeks ago, and so he's off PPI and still endorsing epigastric discomfort. This is a patient was seen by your partner maybe 1 week ago, and the partner ordered serum antibody testing and come back positive. So what to do? It's useless, right? So obviously there's useless tests if you're trying to follow up with the patient, especially in this case. This is absolutely useless. So you have to use, next step would be to either use a fecal antigen test or urea blood test. Make sure that patient is off PPI. Either of these tests can be useful. Now, if the fecal test come back positive, the next steps would be quadruple therapy with either flagyl, PPI, bismuth, tetracycline, or you can do amoxicillin, PPI, levaquin, one of those salvage therapy if the your fecal antigen test is positive. The reason why, like I said, is because of the high resistance for the clarithromycin and also for the flagyl. Right, our last questions. We have a 53-year-old female with a history of osteoarthritis being evaluated for recent hospital admission after upper GI bleed due to the gastric ulcer. So EGD showed that a non-bleeding clean-based ulcer, and the patient was discharged on PPI. So what will be the next step? Patient has OA, and she's taking ibuprofen for her osteoarthritis. So you tell them to stop the NSAID. That is number 1 step, important step. Now let's say this patient's come back in a couple months and patient stating a severe knee pain, and she tells you, what, doc, I am taking Tylenol around the clock, it's not getting any better. So patient needs some type of pain regimen, and your next step would be give them topical diclofenac, topical NSAIDs. That would be the top next step. Let's say a patient come back again in 2 months and tell you that, what, it's not getting any better, just a little bit with the diclofenac. Your next step would be to start them on a COX-2 inhibitor, such as celecoxib, with the PPI. So that will be your salvage therapy to make sure, to help with the pain and also to prevent the ulcer. The patient need to be on PPI. So that concludes our GERD and PUD video topic. Like I said, this is the second video series of the Gastroenterology and Hepatology series. If you like the videos, please let me know. You can comment on the video, or please like the video. You can follow my channel. I'll be making more videos in the coming weeks. I know the exam's coming up in a few months, so if you guys have any questions or any other comments, please let me know. Thank you.